After configuring the provider-initiated programs, we continue with the configuration of the patient-initiated programs. From the total notification input and the distribution of patient or case types defined by the inputs, the model calculates the number of target population patients in different pulmonary, age, and HIV categories. From the provider-initiated programs, the user obtains the number of patients, assumed to be notified aged 15 plus, and HIV negative from the household contact and high-risk group programs. The model deducts these patient groups from the groups with which they overlap in the patient-initiated program. Therefore, for patient-initiated population groups, the tool starts with the number notified in each category and calculates how many patients must have been clinically evaluated for the algorithms to result in the calculated number notified in the patient group. For further details on this calculation, the user can consult the user manual and embedded guidance. While the calculation follows directly from the screening and diagnostic properties of the clinical evaluation and diagnostic algorithm configurations, the process can be undone by too many notifications resulting from the provider-initiated programs, leaving too few patients to be found in patient-initiated programs. Attention must be given to the situation during the validation steps, for which a guide is given in the target population validation video. There are 10 patient groups selectable from the TB case type selector. First, pulmonary TB among HIV-negative children aged 15 years, HIV-negative adults 15 years and above, HIV-positive not on ART children aged 0 to 9 years, HIV-positive not on ART children aged 10 to 14 years, and HIV-positive not on ART adults 15 years and above. Then extrapulmonary TB among HIV-negative children aged 15 years, HIV-negative adults 15 years and above, HIV-positive not on ART children aged 0 to 9 years, HIV-positive not on ART children aged 10 to 14 years, and HIV-positive not on ART adults 15 years and above. Noting that 1. We use an identical group structure for pulmonary and extrapulmonary TB. 2. Only PLHIV not on ART is handled in patient-initiated programs. PLHIV on ART are represented only in provider-initiated programs. And 3. All extrapulmonary TB patients are handled in patient-initiated programs. Let us review the inputs required to configure the pulmonary TB, HIV-negative, children aged 15 years population group. The other groups work the same way. One of the main differences relative to provider-initiated programs is that we do not define the population sizes as we do in provider-initiated groups. We do not have WHO data on the number of patients who are clinically evaluated by group. This number is estimated from the other inputs, namely TB prevalence, clinical and diagnostic evaluation sensitivity and specificity, and the total number diagnosed and notified. Therefore, patient-initiated patient groups have fewer tabs, namely 3 in total. TB characteristics and clinical evaluation, TB diagnostic evaluation and outputs. In the section TB characteristics and clinical evaluation, we see a repeat of the layout used for provider-initiated programs. See provider-initiated video. Data review and revision should be complete for each section of this tab. Users should review and revise the entry for prevalence among persons presenting at the facility if there is better local data available. We do not require the input of an estimate for the prevalence of TB infection, a key input for TB preventive treatment target population calculations, as the model design assumes that preventive treatment is given only via provider-initiated programs. The tool provides a default value of 10% for all countries for TB prevalence among patients seeking care at health facilities. This, working together with typical values for the other inputs, leads to a value of 10 for number needing testing, a default value that is often used for the costing of traditional screening approaches in patient-initiated programs. A country, especially those with broader eligibility criteria than traditionally used, for example, eligibility for clinical evaluation following any TB symptom instead of 2 weeks cough, may have estimates for TB prevalence among these patients of well below 10%. The clinical evaluation algorithm is set to common practice by default, parallel symptom screen and chest X-ray, but users can select the option for a custom algorithm and adjust as needed. The screening algorithm will have an associated and non-editable sensitivity and specificity, which will define numbers of people who are screened to achieve a given number of people diagnosed and notified. The selection of a clinical evaluation step follows the same approach as for screening in provider-initiated programs. Select these from a default list or configure a custom algorithm. Generally, default options are fewer when clinical evaluation happens at facility level and where X-ray methods are available and form a critical and recommended part of evaluation. Care should be taken not to configure a custom algorithm that is not appropriate at health facility level. The output structure at the bottom of the tab is the same structure used on provider-initiated programs, but values will be different generally, with patient-initiated programs having superior yield and lower number needed to test owing to the higher prevalence of TB disease among patients seeking care at health facilities than patients found through systematic screening in provider-initiated programs. The inputs and outputs for TB diagnostic evaluation are the same as in provider-initiated programs, and generally patients are referred to the same diagnostic services whether they come from patient or provider-initiated program. The output structure at the bottom of the tab is the same in structure, but values will be different generally, with patient-initiated programs having superior yield and lower NNTT owing to the higher prevalence of TB disease among patients referred for diagnostic evaluation in patient-initiated programs. The output section show intermediate results that reflect the cascade of care for the population currently selected, including number clinically assessed for TB disease, the number referred for diagnostic evaluation of TB disease, the number diagnosed with TB, and the number initiated on treatment for TB disease. These outputs can be reviewed and compared with service statistics to refine the inputs such as the clinical evaluation algorithm and diagnostic method choice, TB prevalence, and so on, for the patient-initiated population considered.